Hello.
Hi, this is Pooja.
Hi, this is Emily Wine.
Hi, it's
Hi.
Angela. Thanks for joining speakers. You guys have been unmuted. Everybody else is in listen-only mode. And we'll start shortly.
So I have called in from my cell phone. Is that what I'm supposed to do? This is Pooja.
I think that's fine if you use your cell phone to dial the number that was provided for you when you joined the GoToWebinar.
Yeah.
Okay, yeah, that shouldn't be a problem. You have a good connection, and we won't lose you.
Okay.
And how do we control the slides?
So what I'll do is I'll advance them for you. I have them all together, and it just sort of makes it easier.
Okay, I'm going to go pretty fast. This is Emily, just because. Should I say next slide?
You can say slide or next slide. I'll keep up with you. No problem.
Okay, cool. But I don't see anything now. Is that okay?
Right. Let me share my screen in just a minute.
Cool. Okay. This is Emily again. My time is 20 minutes, or is it 15 minutes?
20. I think we both got 20, and 15 was for questions.
Okay. Hi, this is Alana from MHCC. Can you hear me?
Yeah.
Yeah.
I can hear you.
All right. Hi. Sorry, I got disconnected for a second. Angela has informed me that you both have 20 minutes to present. Just wanted to clarify that. Great.
Hello, everybody. This is Angela with the Maryland Healthcare Commission. Thank you for everybody who is joining us for this webinar session. We will allow a minute or so for people to make sure that they're on the webinar, and we'll get started shortly. Please note you're in listen-only mode for now, even though you've entered the audio pin, but we will unmute people for the question and answer session. So please hold. We'll get started shortly. Hello, everyone. Again, this is Angela Ebat. We want to thank everybody for joining today's webinar on navigating telehealth compliance and reimbursement. This is the third series of a multi-part series of learning lessons focused on implementation and sustainability of telehealth. I want to thank you again for joining us. We're very excited to bring you today's webinar highlighting key topics on telehealth compliance and reimbursement. Our hope is to shed some light on the many questions raised regarding telehealth reimbursement and also general compliance in terms of privacy security and the legal can and can't do's of telehealth, both at the federal and state level. We have selected our presenters as they are experts in the field on compliance specific to telehealth and reimbursement. Given the number of compliance and reimbursement topics that are important to cover, we're aiming to keep this presentation at a high level and highlight key items. If there's an interest from the community, and we think there is, we'll provide a deeper dive into some of the topics highlighted today. So please don't get discouraged if we don't do a deep dive into some of these topics. We ask that participants provide feedback on which topics they would like to get a deep dive into in the survey that will follow this webinar. And we'll provide you some details about how to respond to that survey. Before we get started, I'd like to cover a few housekeeping issues. First, we are recording this webinar to make available to those who aren't able to participate today. Second, at this time, all webinar participants are in listen-only mode, just to limit any background noise during the presentation. After the presentations from our speakers, we'll have 15 minutes for a Q&A session. During that time, we will unmute participants so they can may ask questions. In order to unmute participants, you must have entered your unique audio PIN followed by the 9-digit access code. If you haven't, you should find this audio PIN in the audio settings of the GoToWebinar menu. Participants who have questions should raise your hand using the hand icon in your GoToWebinar menu. When we do unmute you, please be sure not to put us on hold and try to reduce or eliminate any background noise that may occur on your end. You may also include questions during the presentation in the window within your webinar, and my colleague will read these aloud to allow our presenters to answer during the Q&A session. So to get started, our first presentation is Navigating Telehealth Compliance. Our speaker is Emily Nguyen with Baker Donaldson. Ms. Nguyen advises healthcare clients on a wide spectrum of regulatory matters, including telemedicine, Medicare, Medicaid enrollment, HIPAA privacy issues, on alternative bundle payment models, Stark and federal anti-kickback law compliance, and other fraud and abuse topics. I'll now turn the presentation over to Ms. Nguyen.
Thanks, Angela. Thanks very much. And just to echo what Angela said, this is going to be more of a high level. I have included a lot of material, however, in my slides in the hopes this could be a useful take-home resource for you all. But I will just, on some slides, touch on them briefly. But you will have these, as my understanding, to take home as a resource such that it goes into a little bit more detail. So next slide, I thought I'd start with, there we go. I thought I'd start with what I think is probably a most relevant and exciting area as it pertains to Maryland these days, and that is the developments in the professional licensure standards. Next slide. Currently, physicians and the Board of Audiologists are the only final regulations that are out there as far as professional licensing goes. However, last year's legislative session mandated several boards to promulgate, and propose, and publish for comment other telehealth regulations for their professions. And they would include this Board of Psychologists, Board Examiners for Psychologists, social work, nursing and counselors, and therapists. We are seeing a lot of flurry of activity. We have the draft physician regulations, which I'll touch on a bit. We have proposed psychologist regulations, the Board Examiners for Psychologists regulations out. We hear the social work is coming, and then the other two boards, I think they have a few more months to do that. So I thought I'd start here. With Maryland, not one is going to look the same, so you have to be very mindful as to what profession, what service line you are dealing with to understand the realms and the barriers of telehealth. Next slide. As I said, it's been in a state of flux. You mean to start to date, at least prior to the proposed regulations, the term of art in the Board of Physicians regs was telemedicine. And you can see what that, the definition here, but the proposed regulations, next slide, really broadens the scope to telehealth, which is, you can turn to the next slide, which is really the common nomenclature these days. And unlike the prior definition, which was very brief and very general, this really does nail down into the modalities of telehealth, which is always a question. And we'll talk about why when we get into Medicare, what really is covered as telehealth under a certain professional regulatory schematic, and what's excluded. And very, very common to many other states' professional licensure boards, and particularly Board of Medicine, you're not going to find coverage for audio-only telephone conversations or emails or faxes. This is really a synchronous or asynchronous, back and forth communication where you want to have something visual, something audio, and these new proposed regs really do highlight that for us. And they also have a new terminology or a term, a telehealth practitioner, to widen it from, acknowledge that it's not just physicians who are involved perhaps in telehealth, even when regulated by the board. Next slide. So a couple things that are consistent to the old regulations under the Board of Physicians are licensure. They're of course going to require a Maryland licensure if the patient is located in the state. But interestingly, and I believe a topic of conversation at the board is that the license has to be required if the practitioner is in the state as well. So you have both. It's interesting how they may regulate, perhaps, maybe that's not the intent, telehealth being provided to another patient outside of Maryland, but that again is to be determined. These are just in proposed format. A lot of different standards and disclosures common to many states. Boards want to see certain information shared with the patient. We had this in the original rules, identifying the types of communications at hand, identifying the qualifications of the physician. In the proposed rules, one thing that was of interest is the current requirements are still in play, but one thing is very much of interest, which was really asked for by the stakeholders, was to emphasize the fact that the same standard of care required in the in-person setting is what is going to be required in a telehealth setting. So not to make anything too more burdensome when not necessary, but the same standards of care applied. And while not expressly stated, there is this suggested allowance for establishing a patient relationship through a telehealth encounter. Next slide. Patient consent. This has been something, this is definitely a little bit of a change. Consent was required by the Board of Physicians prior, but there wasn't a lot of detail. Now, while the consent terminology is referred to as an acknowledgement, there are still a multitude of things that need to go into that acknowledgement to meet the regulations. And while these are still in proposed fashion, there are some thought that these are a bit burdensome as far as the various disclosures that had to be made. How would you actually document that? How would you document all of the risks that are inherent in telehealth? The thought is to just allow the professionals to adhere to their typical standards of care and not to prescribe it. But again, these are still in draft form. You'll see emergency and contingency plans for either, emergency clinical conditions occurring during a telehealth encounter, or if the technology simply fails. That is something a little bit different than the in-person setting. So understandably, it's something that's addressed in the rules. Record keeping, privacy and confidentiality, all things consistent with other states, as you see, other state Board of Physician or Board of Medicine regulations you're going to see in Maryland as well. I'll just mention the Board of Physicians, their regulations, like I said, are still in draft form. I believe comments are still being accepted for another week or so, and we will see where we go from there. As of now, like I said, Board of Examiners and Audiologists are the only ones that, other than the Board of Medicine, Board of Physicians, that are proposed and in final form. And what I wanted to highlight here, which is something to keep in your mind when you're seeing these other regulations come forward, is telehealth or fill in the blank is not always consistently defined. And I believe, it's my understanding, that when the legislative mandate came out for all these various boards to issue telehealth regulations, one part of that mandate was to be as consistent as possible, because it's very difficult to, even though understandably these service lines are differing in your definitions of what a telehealth service and the technology allowed is hard to manage, particularly if you're a multi-specialty group practice, trying to offer various services and knowing which kind of technology is okay to provide medicine, but maybe asynchronous technology, which is store and forward, storing an image and forwarding along for diagnosis and treatment. Perhaps that asynchronous modality is not prohibited, not permitted in another specialty. So a lot of attention and detail must be paid to these various regulations as they're coming out, and it all comes, as lawyers say, it all comes down to the definitions as to what constitutes telehealth and the various aspects of it. So a lot to pay attention to, and stakeholders need to voice their thoughts on those. As I said in the beginning, we have proposed Board of Psychologists regulations and Board of Social Work we think are forthcoming, and we're going to be on the lookout for the Board of Counselors and Therapists and the Board of Nursing as well. Now, we're going to shift to Medicare and commercial payer reimbursement. Medicare, not as fast moving as some of the state regulations as everybody would like. As I say, typically there needs to be the perfect storm, next slide, for Medicare reimbursement. Here are the various resources you can look to see the details of the benefit, but really you need to have 5 key elements for your perfect storm. So next slide, we start with geographic location. Geographic location pertains to the originating site where the patient is. Okay, so the patient has to be in a rural area or underserved area. There are certain exceptions for demonstration projects, but for the most part, they're in HIPSA or those outside of a metropolitan area. Next slide. Added to that is the originating site within that geographic location. Next slide. And you'll see in the various regulations and manuals that I say at the beginning, you have a comprehensive list of what those originating sites are, but not long enough if you ask anybody who's really trying to make an impact and really increase the access for patients, because in one big area missing, the home. The home is not qualified as originating site, so all these new awesome direct-to-consumer, reach anybody anywhere, all the people that need it type services are not going to be covered under Medicare. Added to the originating site and geographic location are a distance site providers. Not everybody, next slide, can be a distance site provider. You have your common professions, but we don't see here therapists, physical therapists, occupational therapists. I know that's one lobbying effort or stakeholder effort that has been pushed. You don't see that. And you also don't see federally qualified healthcare centers. That has been one push in expansion of Medicare telehealth reimbursement, having those centers actually be a qualified distance site provider. But again, the point here is it's limited. Added to my perfect storm, you're going to have the proper technology platform. I mentioned in the next slide, the professional licensing part, that in Maryland, asynchronous store and forward, those images that you take and you send them off are included in the concept of telehealth, at least according to the Board of Physicians, but not Medicare. Medicare requires you to be synchronous, video and audio at the same time occurring. So that a store and forward does not constitute it unless you're in a demonstration program in Hawaii or Alaska. And remote patient monitoring, another very key hot area right now, particularly with chronic care patients, is not included currently in Medicare reimbursement. And then, of course, after you have all of the stars aligned with that, and you have all the right technology, the right people, the right location, you have to have the right services. So next slide, covered services are very limited. There were a few that were added for purposes of calendar year 2018, but generally, you have about 45 services, 90 codes. There's a push for more services to serve critical care populations, more services to service dialysis patients, really contributing to the reduced cost of healthcare and increased patient quality. That's triple aim. So those are when you see pushes, we see them there. But right now we have a limited list of covered services. Next slide, basically you can get them, stakeholders can request additions, but they actually have to be so similar to the already allowed upon list that, it makes sense to include them. Or if they're not, they have to, you have to really make a very strong case for the demonstrated benefit. And to date, Medicare is not 100% convinced that telehealth saves costs. So we just need to have a lot. I think they're understandably amenable to the concept that it's an improved quality of care delivery, but they're not so sold on the fact that it actually reduces costs. And probably a lot of the reason is that there's not a lot of long-term data out there to show avoidable acute care admissions or more costly episodes of care. So as the data keeps coming in, hopefully that will be an easier argument to make. But right now, it's a little bit of an uphill battle. So Category 2 services are not so much an easy argument to make when it comes to adding codes in that vein. I'm going to continue on with with billing. So it's somewhat simple at this point. The originating site is going to bill a code to identify it as the originating site, and they're certifying to Medicare that they have met all the requirements, so the location, the type of site. The facility fee varies. It's around $25, but it will vary. Next slide. Vary based on the type of facility that you are. So, but it hovers around $25 for the most part. Next slide. The distance site also has to submit with a particular modifier for telehealth, and that's the GT modifier. Again, there's a certification that goes along with that the patient was at the right site. If you are providing an ESD covered service, then you've met the hands-on or in-person visit requirement in connection with these services. And this essentially has been eliminated. But I wanted to take a time to describe it because it is at times, it is used sometimes by some state Medicaid programs, but our expert will speak to that when she comes on. But what is used now is a place of service code 02, but it still conveys the same thing to Medicare, which is this is a professional service rendered by a qualified distance site. The G2 modifier is still being used, but again, that isn't really relevant to Medicare. I just want to put it in here to close the loop because relates to services and demonstration projects, but to the extent it's relevant, I wanted to include it here. Then when the distance site submits its claim, they're going to get the regular physician fee schedule rate, okay, but it's just going to be codified as a telehealth service. And again, when Medicare and Medicaid are in play, the originating site where the patient is, which is what I emphasized before, is those laws are always going to control. Here are some limits on the amount of what to the extent you're a hospital facility. Here are the extent, some limitations on the amount of consults that can occur. You know, you have limitations on hospital services, 1 every 3 days, nursing facility services, 1 every 30 days. So you want to be mindful of that when you decide to institute telehealth services into your facilities. And I just touched on here generally what legislation is aimed at expanding, whether it's expanding the list of covered codes, where services can be provided. There is a host of places that you can expand this. I mean, the benefit is truly limited in every area that applies, or every requirement that applies. It's very, very narrow, and not, if you ask any stakeholder, really allowing telehealth to operate at its full potential. Medicaid has more flexibility, and so do private payers, but we'll hear from Medicaid later. And then as far as private payers go, commercial payers, next slide, you know, they have a lot, because they're private, obviously, they have a lot more flexibility. But the key here to keep in mind is what sort of payer rules are in play in your state, in Maryland for us. And these are referred to as parity laws. You know, is telehealth required by the Insurance Commission to be treated the same? You know, do payers have to treat them the same, afford parity? Well, generally, yes, but you have to dig deep into your state's laws, because one parity is not always the same. There is a concept of coverage parity. Does it have to be covered equally, or does it have to be paid equally? I mean, in the worst case scenario, the plan can say, well, sure, we cover telehealth, teleconsults, but we only pay half. Or we'll have payment parity, but we're not going to be required to cover it. So you have to have both to really have an impactful commercial payer environment. Next slide. So just to note that insurance law also has its own definition of telehealth, so be mindful of that when we're trying to decide what parity laws apply or how they apply. And here in Maryland, there we are, next slide. I would say, yes, we have coverage parity, but payment parity, I think in practice we do, but the law is not terribly clear. Insurers must reimburse for covered healthcare service that can be appropriately provided through telehealth. Requires coverage of telehealth services under a health insurance policy or contract for healthcare services appropriately delivered for telehealth. It says that they must reimburse them, they can be appropriately provided, but it doesn't say how much. So, you know, it's just something to be aware of. And so when negotiating commercial contracts, remember that you should put effort towards negotiating the specific terms. You don't want to rely on the fact that Maryland's going to require the reimbursement to be the same. You want to make sure that the negotiated provisions are very, very, very clear on that. I mentioned earlier, next slide, that commercial insurers can be a lot more progressive. They can have their own sort of clinically integrated networks that will reward reduction of costs and increase in quality of care, similar to an ACO. So telehealth is often viewed as one of those tools. So to the extent that your payers do have those programs, this is one way to use telehealth. And, you know, a lot of telehealth for employer benefit programs want to offer telehealth as another employee benefit, a value add. So there are a lot of creative veins to access telehealth through private payers. HIPAA and privacy security regulation. So probably one of the most key legal issue in compliance when I think of telehealth, and there are a multitude of others. But if I were to say number one in this environment, it would be privacy and security. Next slide. Just with the uptick in enforcement, all of the very strict breach notification and definition requirements under HIPAA via the HITECH Act, and all of the exposure. I mean, you do have a lot of direct-to-consumer models out there. People want to see their doctor on their iPhone, on their iPad, but the more access, the more use, I mean, naturally, it's going to be more risk exposed. Next slide. Particularly when you have provider-to-provider telehealth offerings, you have integrated medical records. We can go back to the slide before this one. The integrated medical records are an issue. You know, how to share information, but do it in a secure manner. Do both sides have compliant security and privacy policies in place, or business associate agreements in place? And remember, it's not just HIPAA. Next slide. It is the Maryland medical records laws. And that are sometimes more stringent than HIPAA. So you have to review your telehealth offerings, telehealth platforms in concert with all of these laws, including even the PIPA, Personal Information Protection Act. This applies to breaches and loss of information of things like Social Security numbers, bank accounts, things that not healthcare related, but still notice obligations are going to apply to those as well. And the final area that I'm going to be touching on is the remote prescribing rules. And I think this is another very, very hot topic. Next slide, because obviously of the opioid crisis going on right now. We have this crisis. We have this overutilization of opioids. We have, the push to use telehealth, and then we have some archaic federal rules in place. Next slide. The Ryan Haight Act, which many of you may know if you know about ePrescribing, was put in place when a teenager, Ryan Haight, was able to fill out a questionnaire and get some painkillers or some, I'm not exactly sure the exact drug, but you probably can assume the story. He got them, he used them, he died. So the Ryan Haight Act was really to battle online pharmacies where you could simply create a form or fill out a form, and you would be able to receive a prescription from a prescriber. You will see most states have a similar prohibition on online forms, online prescribing based on forms, but it's the latter, it's the next step that most states are struggling with right now, and that is, how does the practice of telemedicine fit in? Because under the Ryan Haight Act, there are some exceptions. You can provide a prescription to e-prescribe a drug to a patient or individual, create a patient relationship based on a telehealth encounter in certain circumstances. So here are the exceptions to the Ryan Haight Act, provider to provider, patients in the hospital, if there's a telepresenter, but those really don't cover, I would say, the bulk of what people are doing now or want to do, like the direct to consumer, people out in the community. And oftentimes the people who really need the access most are not in a clinic or not in a facility, but really to reach them in their home, in another setting, to prescribe remotely. It would be, a very effective manner, because what states are pushing for, a lot of prescribers are pushing for, to be able to do this for controlled substances. Many states like Maryland do have, or many states, and I'll get to Maryland in a second, do have different treatment of non-controlled and controlled. And you'll see, of course, like the controlled substance regulation is the more stringent. And oftentimes states don't allow you to remote prescribe a controlled substance unless you've had an in-person consultation with that patient. So there goes remote prescribing or e-prescribing via telehealth encounter. We can probably skip 2 slides right now to the pharmacist slide. Right now, there is a lot of deference given to the pharmacist to receive it. If they received a remote prescription from prescribers, if they felt it was a valid prescription, they could fill it. Now, of course, you would have to adhere to the Ryan Haight Act, which does not allow controlled substances to be prescribed unless there are those exceptions. But the Board of Physicians did recently propose a regulation that addresses the subject. Next slide, please. As we would expect, there's no prescribing based on an online questionnaire, just like the Ryan Haight Act. And there is no prescription for opioids used through telehealth, just like many, many states. However, these proposed regulations limit that to no prescription through opioids to treatment of pain, except if the patient's in a healthcare facility, which some may feel is leniency enough to reach the patients as much as they possibly can, the patients who need it. However, keep in mind, this is not, this Maryland regulation does not allow for prescribing via telehealth to an individual who's at home in a direct-to-consumer model telehealth offering. But even if it did, even if Maryland law did, Ryan Haight, federal law is always going to trump. So you had this battle back and forth between Ryan Haight Act, which is pretty stringent on the controlled substance and definitely doesn't allow it when a patient is not in a facility or all the other narrow exceptions are met. And now we have Maryland law as well that has these limitations. So I think people are pushing for expansion on on expansion on the federal side, and that would hopefully lead to some expansion on the allowance for e-prescribing, whether it's controlled substance or not in each state. But really, in my opinion, it's going to have to start with the Ryan-Haight Act, because at the end of the day, you're always going to have to deal with that, which is pretty limiting, particularly for these telehealth models that people are understandably so trying to institute. And so I'm just going to skip over these last two because I think I kind of covered it, and I'm going to turn it over to my co-presenter.
Great. Thank you, Emily. I appreciate that. That was a wonderful presentation. Lots to cover. So we are going to move on to our next presentation, which is from the Maryland Department of Health. Our presenter is Pooja Rejima, and she is a health policy analyst with the Office of Healthcare Financing, and she'll be talking about Medicaid side of telehealth coverage in Maryland. Pooja?
Thank you, Angela. So I wanted to first send Nina's apologies along. She is under the weather, and she was going to co-present with me today. So I will be presenting on a high view of Medicaid telehealth coverage in Maryland. Next slide, please. Emily covered a little bit of this earlier, but so I'm going to brush over this. But she covered live video, store and forward, and remote patient monitoring. So remote patient monitoring is bolded because we have coverage for that as recently as January 1st of 2018, and we're going to cover that in a few slides in. Store and forward in Maryland is not covered by Maryland Medicaid. It's when medical images are transmitted. There's no interaction between the originating site and the distant provider, and it's used with teleradiology, teledermatology, and teleophthalmology. And again, that's under the physician services. Next slide, please. So this is a list of permitted originating sites for telehealth. It's a pretty exhaustive list, but similar to what Emily highlighted with Medicare, patient's home is not listed as a permitted originating site. Next slide, please. And then this is a continuation of the permitted distance sites for telehealth. The physician assistants and the federally qualified health center, the last two bullet points, there's regulations pending on that, and I've attached, when the slides are distributed, you'll be able to see that the COMAR link for the proposed rules on that. And the newest addition for the distance sites is, as of October 1st of 2017, community-based substance use disorder providers, opioid treatment programs, and outpatient mental health centers are permitted distance sites for telehealth. Next slide, please. So again, this kind of highlights the new providers that I just listed as of October 1st, 2017. And there are new codes available for alcohol drug assessment and alcohol drug individual counseling and therapy. Next slide, please. So under current coverage, Maryland's telehealth programs administrative requirements, there's been a streamlined registration process available online for provider billing and education purposes, and provider addendum and application process has been discontinued. Slide 12, I apologize, not 12 here, but a few slides in has a list of regulations and related websites. So that's been bookmarked for all of the listeners so that if you need this in the future on registration process, that is available as part of the presentation today. There's been an enormous growth in providers who have registered to participate in Maryland's telehealth program. So originating sites, we now have 89 somatic providers. Okay, so the next slide, the recent changes in coverage, we have 29% increase in number of originating sites and a 74% increase in number of distance sites registered. Next slide, please. So effective, this is the biggest change under remote patient monitoring with Maryland Medicaid. So as of January 1st, 2018, Maryland Medicaid will reimburse for remote patient monitoring services for certain conditions. The following chronic conditions qualifying for RPM are chronic obstructive pulmonary disease, COPD, congestive heart failure, or diabetes type 1 or type 2. Next slide, please. So the individual who can receive RPM, the participant must be enrolled in Medicaid, consent to RPM, and have had one of the following scenarios happen within a 12-month period. So you have to have either 2 hospital admissions with the qualifying medical condition I just listed as the primary diagnosis, 2 ER visits, or one of both, 1 hospital admission and 1 emergency department visit with a qualifying medical condition. Referrals for RPM may cover an episode up to 60 days of monitoring. Eligible participants may receive 2 episodes of RPM during a rolling 12-month period. Next slide, please. So there were inquiries about the process for RPM. Eligible providers would have to submit a pre-authorization form. And again, towards the end of the presentation, there is a link to the pre-auth form. Services are limited to 2 months and up to 2 times per year per patient. A prescribing practitioner may practice at one of the following locations and prescribe RPM. For a home health agency, the physician must authorize, and the home health agency staff must provide weekly summary to the physician if there are abnormalities. And then the rest of them are listed right on there. Next slide, please. So the RPM rate is an all-inclusive rate for reimbursement of $125 per month, which covers the equipment installation, participant education for using the equipment, and daily monitoring of the information transmitted for abnormal data measurements. It does not include the actual equipment, upgrade to that equipment, or internet services for participants. Next slide, please. There were questions on MCO billing, and we found in researching and for today's presentation that every MCO's billing practice is a little bit different. It varies by the provider. So our best suggestion is to actually contact the specific MCO provider you have questions about for their billing practices. So we've provided each of the MCO providers and their contact numbers on this slide. Next slide lists out all of the resources that I mentioned, from telehealth RPM, the pre-auth form, the home health transmittals that we've published and distributed, along with the website for our telehealth live video, and then our email address if you had specific questions on telehealth with Medicaid, and the COMAR for telehealth services, the regulations. And the last slide is that's my name, Pooja Regni, at the top with my email address, and then Nina, who is in the Office of Health Services, can also answer questions if you emailed either one of us directly. Thank you.
Thank you so much, Pooja. Very informative presentation. And we will note, we really appreciate you providing those resources within the slide. For folks who are attending today, you'll receive a PDF copy of these slides where you'll be able to have those active links within that PDF. So if you're clicking on it now, it probably won't open, but you'll get it in your inbox. So we'll now open it up for questions and answers. We have a significant number of people on the line who are participating, over 100, which is great. We're very glad to see those numbers. But instead of unmuting 100 people, we think it would be best if folks either type in their questions, and my colleague Alana will read them aloud, or if you want, you can raise your hand, and then we'll call on you in the order as much as possible in which it's raised, unmute your line, and allow you to ask the question. So I'll turn it over to Alana.
Thanks, Angela. Our first question comes from John Cornack. It's a question for Emily. John asks, for record keeping, you mentioned that you must stay compliant with federal and state law. With CMS meaningful use and many other interoperability requirements, is it a requirement under telemedicine to have access to the patient history at the time of the telemedicine encounter via electronic medical record, or just whatever way possible, which includes a paper trail? Okay, so that's a very good question. As far as having access, so I'm thinking, and there are various ways of telehealth, and maybe just because it's not paid for or covered by Medicare or Medicaid, there are various offerings and modalities that you can have it. So you have direct to consumer. You're not going to have the patient history. If I understand the question, it's how are you expected to, or how are you required to have access to that prior history? Well, if it's the first time that you've encountered this patient, then you're not going to have any history. You have to rely on that patient to provide the relevant information, and based on the provider's rendering, has to adhere to or has to defer and use his professional judgment as to whether or not they have enough information to render the service. And I'll note that in the Board of Physicians proposed regulations right now, there is a provision in there that states the telehealth practitioner or physician needs to note when it may not be clinically appropriate to render services to a physician, to a patient. Perhaps that's when they don't feel like they have enough history. If you're talking about a provider to provider scenario, and you have a solidified relationship between I'll say in-person bricks and mortar type facility or clinic, and with a telehealth provider, one gold standard or hope is that you could integrate in a compliant, private, and secure way your medical records, such that you would have access to that. So to the extent that they could do that and have it all in one place, that would be great. I don't think, and our practice is very heavily concentrated in Maryland, but we also have clients from across the countries, so we can't make across the country into various states. So I know how their models go, and it's not always they're not always able to. They don't always have good vendor products, or they don't have EMRs that nicely synced with each other. So that can't always be the case. To the extent it's required by professional standards, like licensing standards, actual regulations, I don't know if the Board of Physicians has that requirement yet, but I think it's still something that is more of a gold standard, or the interoperability would be something you'd want to look into for that very reason that John brings up, to have the access to the patient history at their fingertips, the most current information too, and not rely on the patient.
Thank you, Emily. Our next question comes from Dr. Kenneth Lee, who asks if a provider must register with Medicare before providing and billing telehealth services as is required for Medicaid.
No, there isn't a registration requirement like Medicaid. That's a good question.
Thanks. Another question from Jennifer Crawford. She asks, can an FQHC with multiple sites be registered as both an originating site and a distant site so that patients can come into one site and be seen at another site?
Okay, yeah.
I believe that was for Medicaid, Suja?
Yeah. I'm actually not clear if an FHAQ can be both originating and distant, so I can definitely give a response back to Angela. And Angela, do you think you could send that forward?
Absolutely. So we're getting a number of questions within the window. If we don't get to your question today, we'll definitely pass these along to the appropriate speaker for response. So no worries. Next question.
Perfect. Thank you.
Thanks. Our next question is from Elizabeth Himmel. She asks, what is the site code for OMHC providing services for Medicaid? Also, does Maryland Medicaid allow services in the home for mental health services?
So again, the first question, what was the code question? I'm sorry.
What is the site code for OMHC providing services for Medicaid?
OMHC. I will again have to provide that. And as of right now, I know that there's discussion about the mental health component, but it's not necessarily covered currently under from the home.
Thanks. Our next question is from Mary Miller. She asks, does Maryland cover remote psychological therapy services provided by psychologists as opposed to a psychiatrist?
That's not, with Maryland Medicaid, that's not currently covered. I know that's been proposed and discussed, but it's not currently covered.
Okay. A question from Sam Rashkovich. Where can I learn more about the state codes and regulations for telemedicine, and what is required technology-wise at the distant site?
This is Emily. You can monitor, and I think there's going to be a flurry of activity in the coming months, and you should monitor the Maryland Register. It's available to the public, and you can look at the daily issuances there and follow the boards, or the professional licensing boards there. As far as the technology, if you're talking about the types of technology, whether it's synchronous or asynchronous, board by board, they're going to, as I mentioned, they're going to define telehealth a little bit differently and what's permitted. Nailing it down, getting even further into the weeds, the regulations at this point don't go into detail regarding that. They of course want them to be HIPAA compliant and state law compliant as well. But anything further than that, and maybe someone can tell me if I'm wrong. I know we have some experts on the phone probably listening here, but I don't think there's any further details as to the technology aspects.
I will say I agree with what Emily just said. There is Maryland Medicaid put out a frequently asked questions list on January 3rd, and there's a section under the FAQs on technical requirements, which lists COMAR's 10.09.49.08 listings. So there's several questions on there directly related to technical requirements for telehealth.
Oh, great.
Great. We have a couple of questions regarding telehealth services being provided across state lines. The first one is from John Thierman, who asks, as my interpretation of MHCC position was that DC and Virginia physicians could practice medicine if the patient is in Maryland, but Maryland licensure is required. Can you clarify?
Sure. So the board did release requirements around parity in terms of licensure, and they will accept a license from another state as long as that state also reciprocates the parity in terms of licensure. At this point, our understanding is that there is a process in place as it relates to DC. In terms of Virginia, we're currently looking into it. We've been reaching out to the board regarding their processes and details. Again, this is only recently put in place, so there are still some details that would need to be fleshed out in terms of administrative processes. But at least as the rule is written, Maryland would accept a licensure parity with another state as long as they reciprocate.
Great, thanks. And kind of a follow-up, Josh Susel asks, if you have a client who goes to college in a different state with commercial insurance, do you need a license in the state where the client is or where you are practicing from?
Emily, do you want to take that one?
Yeah, so if a college student is in Ohio, I guess. So Ohio, and I don't have Ohio's laws in front of me, but I'm going to bet 99% they're going to require Ohio license Ohio license for a Maryland physician to provide telehealth to that patient, unless there are some exceptions or clarifications that a Maryland license, the Ohio license requirement is satisfied by a parity rule, like I hear we're having, like in Maryland, or some other exceptions, but most states require a license in the state where the patient resides or is present, because they're going to be the originating site.
Thanks. So our next question then from Andrea Mathias. Is there a provider registry process in Maryland for a physician providing telehealth but not billing to Medicare or Medicaid?
Not that I'm aware of, but
I don't know of one either.
Right, our understanding is there isn't one in terms of registering as a provider if you're not billing Medicare or Medicaid.
And maybe a related question from Dr. Kenneth Lee. Are self-insured employers required to cover telehealth services as opposed to commercial payers in the state of Maryland?
I don't know.
Yeah.
I'm not sure. Do you know?
No, I don't. I'm not aware of what the rules are for self-employed providers.
We can definitely follow up with you on that, as the law is under the Maryland Insurance Administration's jurisdiction, and we'll make sure to follow up in terms of that question.
Yeah, I mean, if they're going to fall under the definition of a payer that's subject to the parity laws, then yes, but we'll just have to confirm that.
Mm-hmm.
Okay, thanks. Sandeep Poulim asks, do Maryland MCOs cover secure messaging between a provider and a patient?
Again, MCO-related questions, because they varied so by the provider, it's specific to that MCO. So I really recommend contacting the specific MCO you're inquiring about and what they require.
Thanks. And again, that is the contact information provided in the slides that will be available to you after the event. So another question from Lori Franklin. Which payers are currently reimbursing for telehealth services in the state of Maryland without the originating site type definition?
This is Emily. I would have to look into that. I'm not 100% sure each payer's policies. I'm sure other providers, probably even listening, are more familiar with each payer's policy than I. But I guess we could probably find that out.
Yeah, so I'm assuming this question relates to commercial payers, and each of their policies might be slightly different. The law doesn't specify a definition of an originating site, just that if they cover it what's under that patient's plan, they need to cover it similar if it was a telehealth visit. And that's sort of what Emily's talking about in terms of coverage parity. But there is no explicit details around originating versus distant site requirements on the commercial side.
Thanks. One question from Brian Hinline. Are you aware of any Maryland hospitals using telepsychiatry within an inpatient psych unit? Any regulations preventing telehealth in an inpatient psych unit?
So this is Angela. I'm not aware of any that are. There could be folks using telehealth in an inpatient psych unit. In terms of prohibitions on that, I think it would all depend on if you're talking about requirements under licensure versus. But again, feel free to reach out to us to clarify a bit on your question. We're happy to help.
And this is Emily. Let me just jump in on that question, just because I was working on that very exact issue this morning, but not for a Maryland hospital, unfortunately. But what I can say is that there are going to be Medicare requirements when it comes to in that scope as to who can be admitting, who can be attending, what the proper handoffs are. And I think that I've gotten that question probably from 3 clients at this point, all in different states, all hospitals wanting to utilize telehealth. And so there are just considerations from an infrastructure and staffing perspective from Medicare that you want to pay attention to.
Great, thank you. So I have a question for additional information. If we can provide a link for technical help on requirements for equipment. Is that something we can provide after where they could find more information?
So we don't necessarily have any resources available to point you to particular vendors that can provide technical support. However, there are a couple of places that I would recommend to reach out to. The ATA, American Telemedicine Association, does have a directory of vendors that they put on their website. If you reach out to me, I can point you to those a bit quicker. There is a regional telehealth resource center based out of Virginia that might be able to assist, as well as our alliance here, the telemedicine, the Maryland Telemedicine Alliance as well, so that we can point you to those resources who might be able to assist in finding vendor technology.
Yes, thanks. And Elizabeth clarified that the link that we were referring to earlier for Maryland technical specifications, so that should be in the PowerPoint presentation.
Right, in terms of the Medicaid requirements, yes.
So that will be distributed after the event. And it looks like we have one more question from Sam Rashkovich. He says, I'm assisting a physician trying to put together a telemedicine program. How do I know whether coverage will be insured through Medicare, Medicaid, or a commercial provider?
I'll just briefly state, oh, go ahead.
Sure. So for Medicaid, there are requirements, and again, like I stated, the FAQs I mentioned, I think does a really nice job of giving you very clear steps on how you need to be, what the requirements are for registering through Medicaid. And Emily can likely speak to Medicare and commercial insurers.
So commercial insurers are going to be, payer by payer. So you're going to have to look at their specific offerings, and they may have various types, whether it's through an employee benefit plan or value add or their core benefit package or managed care. But for Medicare, in my slides, I do have references to some pretty good resources, the manuals. There's not a ton of information, but the information that's there is pretty detailed. And again, it goes back to those 5 elements of, I continue to call it the perfect storm, the various things that you need to have in place, the site, the type of, the geographic location, the originating site, the type of service, the distance site provider, and the type of technology that you're using. So all those have to come together for you to be reimbursed and covered under Medicare.
Great, thank you. So that sort of comes to the end of our Q&As. We know we have a few more questions in the window. Like I'd mentioned, we will follow up with you guys on these. If you want to type in your questions, continue to do so. We'll distribute them to the appropriate person to get a response back. I want to thank you for attending today's Lunch and Learn webinar. Again, a copy of the slides from today's webinar will be sent to you, as well as an email that will include a link to our post-webinar questionnaire. It's only about 5 questions. Please take a couple of minutes and complete the questionnaire. MHCC would greatly appreciate it, and responses are extremely helpful for us to continue to make our webinars better. In particular, we're most interested in hearing from you regarding topics of interest that are more of a deep dive, which we've highlighted today, which we will happily create future Lunch and Learn sessions on. So if you want to know a little bit more about Medicaid reimbursement or registration or Medicare billing, please let us know. I want to thank you again. The MHCC looks forward to your continued participation, and have a wonderful afternoon. And a big thanks to our 2 speakers as well. Thank you.